We are your hosts, Nicki Shorr and Jessie Swain, and you are listening to the American Journal of Infection Control podcast, Science into Practice, brought to you by the Association for Professionals in Infection Control and Epidemiology to highlight work published in our peer-reviewed journal, ACHIC.
Join us as we speak to those in the field of infection prevention and control, like us, as well as other experts, to learn about some of the latest research in the field and how it can be put into practice. We hope you will listen in, learn something new, and apply this information to your work. If you are not a researcher already, we hope this podcast will get you thinking about areas where you can carry out your own research.
Jessie, it's so good to talk to you. I'm so sorry that I missed last month.
I'm sorry you missed it too, but I'm glad to have you back.
Yeah, I am. So, we were gone because we were moving my kid into the dorms, and you know how it is, kind of traveling from one colony to another, which reminded me, you know what happens, right, when a bacteria travels from one home colony to another?
No, what?
Yeah, he experiences culture shock. Oh, it's always thank you.
It's another winner.
I'm here all week. So yeah, we're going to talk about linen today. And today, for that, we have Dr. Janet Glowicz. She is a senior infection preventionist with the Centers for Disease Control and Prevention, Division of Healthcare Quality Promotion. She holds a master's in public health and epidemiology from the Health Science Center at University of North Texas and a PhD in nursing from the University of Texas at Arlington. Janet has practiced infection prevention both as a nurse epidemiologist in public health, acute and outpatient settings. She currently assists with outbreak investigations in healthcare settings and serves as the subject matter expert for hand hygiene in healthcare settings. Dr. Glowicz is the immediate past president of the Certification Board in Infection Control and Epidemiology. So welcome, Dr. Glowicz. We're so excited to have you here.
Thanks so much. I'm excited to be here.
Yeah, so like I said, we're talking about linen today. So do you want to kick us off and tell us a little bit about what prompted the research?
So we actually presented or submitted a practice forum, and this is just really pragmatic practice elements based on outbreak response at CDC. So, we were doing an active outbreak investigation and then really looked at the literature related to lots of other outbreaks and really wanted to provide some things to help infection preventionists understand what's going on at laundry facilities. And I loved your joke about culture shock. You can make so many jokes about dirty linen and dirty laundry.
Well, you'll have to share some of those with us so we can kick off some future episodes with them.
We'll air it out now. This is actually a practice forum article based on outbreak response. Based on the research of others and our own pragmatic experiences. And the article on healthcare laundry and ACHIC is intended to give infection preventionists real world instructions and things that they can do when they are working with laundry facilities.
So can you define for the listeners what hygienically clean means with regards to healthcare textiles and why is it important?
Thanks. Yeah, it is important because every patient that comes to a healthcare facility is exposed to laundered textiles. And we don't anticipate that those textiles are going to be sterile. So CDC does not recommend routine microbiologic sampling of laundered textiles because there's no scientifically validated agreement about what a safe microbial load for laundered healthcare textiles might be. The definition used by the Association for Medical Instrumentation, or AMI, ST65, they define the term as being free from pathogens in sufficient numbers to cause human illness. So that's population dependent and it really relies on an infection prevention risk assessment because different numbers of pathogens will cause illness in different patients depending on, their own individual risk factors. There's another definition from a laundry facility certifying agency, and they use plate testing. and they require a total aerobic count and a total yeast count of less than 20 CF colony-forming units per square decimeter. And they also use USP 62 to look for the absence of, or to document the absence of, E. coli, Pseudomonas, and Candida albicans, among other organisms. There's 2 previous studies I'd like to mention. They looked at microbial load at delivery of linen to the healthcare facilities and at distribution to point of use. The first study by Alex Sunderman and his colleagues at University of Pittsburgh, they found that nearly half of cancer centers get laundered textiles that are contaminated with mucorales. And then the second study found that when cultured at point of distribution, only 27% of laundered healthcare textiles met the total aerobic count criteria. They had plate counts from 9 to 4,000 colony-forming units, although levels of fungi were lower, and just over 80% met the criteria as free from fungal organisms. When we think about textile-associated infections, mucormycosis is the pathogen that really gets our attention because it's present throughout the environment and it's most frequently linked to outbreaks of textile-associated infections in the previous decades. And they're really bad infections. They're devastating and they have very high mortality rates.
Wow. I mean, I think this shines a whole new light on the importance of our textile laundering and handling. So Dr. Glowicz, are there other associated outbreaks of linen besides the mucormycosis? And where and how in the laundering process does the contamination usually occur?
So we know that when healthcare textiles are laundered, the process itself, chemical, mechanical, thermal stresses placed on organisms as they go through the laundering process are very effective, except for C. difficile, which has been associated with suboptimal laundering practices. Other organisms that have been associated with textiles are Aspergillus, Acinetobacter, Bacillus cereus, and in fact in 2012 there was a Bacillus cereus outbreak associated with linen handling at a facility with nearby construction. That hospital reported 146 Bacillus cereus bloodstream infections over a 6-month period. So these can be invasive infections, not just skin infections.
Wow.
And then strep pyogenes or group A strep. So yes, there's lots of other organisms. It's not the laundering process. The laundering process is effective, but it's contamination that happens after laundering as the textiles move their way from the washing machine to the patient.
I know that instances like this have happened in NICUs before, so it can be devastating and heartbreaking. What are some other populations that are at high risk or highest risk for infection with this?
One of the things we learned about NICUs that we didn't specifically point out in our paper, but sometimes they receive donated textiles. And sometimes they will place covers over isolates, and then those covers actually become like a high-touch surface. So a NICU has to have processes to make sure that those get cleaned. But we look at patients with longer lengths of stay, conditions that result in acidosis or immunocompromise. So when the skin integrity is compromised, we've seen textile-associated outbreaks, like you said, in NICUs, oncology patients, and transplant patients, particularly bone marrow transplant patients.
Yeah, it definitely makes sense. We know that we are so concerned about hand hygiene and, how we're touching and using other things that are coming in contact with our patients. So linen, it must follow the same standards. So when we're thinking about laundry within our healthcare facilities, I know a lot of healthcare facilities actually outsource their laundry to these offsite contracted providers. Why would they do that rather than keeping it in-house? And would you speculate that if the laundering occurred within the facility of use, that it would be less likely to become contaminated, or is it better to use those contracted services?
So I can't really say whether it's better or not, but there are definitely differences between on-site and off-site laundry. So why would you outsource your laundry? We've heard from the Association for Linen Management that it's the most frequently outsourced service at hospitals. And that, these facilities are amazing. They're large. They can do thousands of pounds of healthcare textiles within hours. So they process really millions of pounds of textiles each year. They conserve water. That's really an important thing to think about. They control the chemical composition, and they automate the movement through the laundry process until it comes out of the washer. And then that's when it begins being handled by people. So when I think about differences between on-site and off-site laundry facilities, one of the things I try to wrap my mind around is, where does the sanitary condition of the healthcare facility begin? So I think of it usually as beginning at the loading dock, because that's where the healthcare facility, things come into and out of the facility. But, I have to ask myself, is the off-site healthcare laundry facility part of the environment of care? And if it is, what standards am I looking for related to sanitary conditions and healthcare personnel working conditions? Are laundry workers healthcare personnel? Are they providing indirect care? I'm really asking those questions. It's just something to think about.
In my mind, I would say yes.
Yeah, I agree. Those are great questions. And you're talking about like standards and regulatory requirements and regulations. And I wanted to pivot to that. The article mentions two U.S. organizations, HLAC and TRSA, that provide accreditation or certification of healthcare laundry facilities, but noted that these are not considered deeming agencies by CMS. So what does that mean? Is contracting with a laundry facility with one of those certifications of value?
So when you contract with a laundry facility that has one of those certifications or accreditations, the main value is that facility has had an external inspection. An external authoritative source has walked through that facility and observed their practices and documented that they meet their standards. But when we say it's not a deeming agency, we mean that a regulator is not going to walk through that facility. If the laundry is done on site, it is subject to construction standards that healthcare facilities are subjected to. It is routinely inspected by surveyors who will visit the site. When it's off-site, a regulator will not go there. It makes it really important for the IP to be aware of what the HLAC standards are. I think they're super helpful. I refer to them all the time, but they lack any standards related to ventilation or the presence of air filtration. And I would just say that CDC has recommended implementation of FGI, or Facility Guidelines Institute construction standards, including negative pressure on the soiled side of the laundry facility and at least one bed of air filtration on the clean side for over 20 years. And you may or may not see those at an offsite laundry facility.
Interesting. So the article also talks about how during this process, from the time of the laundering to the use within the patient care area, there's several opportunities for the linen to actually become contaminated. Can you talk a little bit about how the hazard analysis and critical control point framework was used in this research to identify those opportunities?
Sure. So a critical control point is a place where you can take action to prevent contamination. So we really traced linen across, as soon as it comes out of the processing or the washing machine, I'm going to just call it the batch washer or whatever they use. As soon as it comes out and it's clean, then we trace it from there at the laundry facility all the way through distribution at the healthcare facility. And we identified several places where healthcare laundered textiles can become contaminated. The first one has to do with the built environment. So like I said, does the built environment have appropriate ventilation? Again, at University of Pittsburgh, they related their mucor outbreak to improper construction of the laundry facility. The intakes and the air vent exhaust valves on the roof of the facility were too close to one another, actually did not meet CDC standards. And so part of their remediation of that facility was some construction work to change that ventilation. Built environments that don't have heating, ventilation, and air conditioning systems, that's something that you really want to be aware of when you're looking at the laundry facility. The second spot we looked at was the clean textile work area at the laundry facility, making sure that personnel have hand hygiene supplies, that they're handling textiles minimally, and that they're protecting those textiles even when they're in the laundry facility from exposure to outdoor air. The third critical control point is transport to the healthcare facility. So making sure that cleaned textiles are in clean carts and protected during transport. We looked at staging at the healthcare facility. So usually when it arrives at the healthcare facility, there's a loading dock, and then it comes inside the facility in a staging area where it's separated out into carts that go to the floor. Many times we've seen that area is not cleaned like a patient care unit would be cleaned. And we've seen inappropriate airflow, so negative pressure in the staging area, so that the laundered textiles are exposed again to that outdoor air. And then the last point, critical control point, is distribution at the point of use. So making sure that laundered textiles are covered, reducing linen clutter in patient care areas, and just really protecting that linen from environmental contamination.
So then in speaking to the contact with external air and coming from the loading dock, and then we've talked about HVAC and pressurization and all of those things, those components. Would you then say, based on these recommendations, that it would be not necessarily appropriate to be storing linen in an outside area, or say an external loading dock type area?
So we pay attention to how long the laundered textiles stay on the loading dock. So we've been at facilities where the soiled textiles exit the facility on one side of the loading dock, and then they have a separate door, an entirely separate door for the clean laundry to come in, and they bring it in quickly and store it in a large area. We've been at other facilities where the soiled and the clean laundry leaves through the same door. And then we've seen on the loading docks fairly unsanitary conditions. At one facility, and I'm mentioning this because if it was a food manufacturing facility, they would pay close attention to the seals under the doors at the staging area. So if those doors exit to the external environment and you can see light underneath the doors, then any type of vermin could get in. So rodents, insects, etc. We look at the loading dock for bird droppings. We don't want to see that. So we want to minimize the time that the cleaned textiles stay on the loading dock. We want them to come indoors. And then once they're indoors, we want them to be under positive pressure in an area that's routinely cleaned.
That's interesting. I've actually heard that rodents can squeeze through a hole as small as the size of a pen shaft.
Right. Right. So that's
Oh,
why,
wow.
just looking under those doors for light. If you see light coming through, anything can get through. Yeah.
Wow.
Awesome. Thank
Yeah.
you.
So, all of this stuff reminds me, it gets my heart elevated a little bit because I think about all the policies and procedures that we write and implement. And I'm wondering, the article mentions developing policies and procedures to inspect linen and carts as they arrive at the healthcare facility. Do laundry facilities usually have policies and procedures written on their processes, including loading and transportation? Because if so, that seems like it would be an important document to share with the hospitals that they contract with.
Right. And that's the time to get that document is when you're doing the contract, when you're updating your contract, or when you're initiating a new contract. If they don't have these policies, it's really important to create them. And if they do have them, it's really important to share them. A real pinch point for hospitals are declination policies. And, that's something that we've talked with infection preventionists about. It's just so hard to decline laundry if the cart is not visibly, clean. If you can see visible soil on the cart, or if the covering has been broken during transport, then really the laundry should be returned for reprocessing. But you can't operate a healthcare facility without an adequate supply of laundered textiles. So that's a real pinch point. So we do encourage facilities to be proactive in that contracting process. And then just really in their infection prevention risk assessment, looking for those high-risk patient populations and determining how they would serve them if they had a disruption in their laundry services, or if they weren't able to get laundry that they, could determine was hygienically clean for them.
Yeah, and I think probably a lot of us saw some disruption in laundry services during the pandemic as well. I know we certainly did. And so we've talked a lot about the healthcare facility itself, from the arrival of the linens. So now, looking at from the other side, the actual linen facility. The article mentions the recommendation that infection preventionists should visit laundry facilities annually. So if I, as an infection preventionist, were to go to a linen facility, what are some of the key elements that I should be reviewing while I'm on site?
So we have a checklist in the article, and it's provided as supplemental material. So that kind of guides you through what you should be looking at the laundry facility. Again, it is targeted at the clean side of the laundry facility. And there's actually two checklists, one for the laundry facility and one for the healthcare facility. A quick tip that I learned from another researcher is to take a Google Earth snapshot of the roof of the facility before you go. You can see during outbreaks, we have seen lint on the roof of the laundry facility.
Oh.
And, I think about that and I think, wow, I am seeing lint from a satellite on top of a laundry facility. That is huge. And so knowing that, you can also kind of see where their intake and exhaust vents are, seeing how, far apart they are from each other. So a Google Earth snapshot of the roof. It's really best to do an unannounced visit. So that way you're going to see their routine practices. Again, that's something that you would want to include in your contract. When you get to the laundry facility, look for open dock doors, open window louvers, and then inside the facility, look for the use of fans to draw outdoor air into the clean side, especially. All of these things are signs that the facility is not maintaining ventilation control. When you're inside the facility, it's important to see how carts are cleaned, what disinfectants are used, how the work surfaces are cleaned, how the linen is protected until it's packaged for transport. And, I have had laundry operators say to me that carts that are only used for clean laundry, for clean linens, don't need to be disinfected. which is untrue. All carts, even if they are only used for clean linen, need to be disinfected on a regular basis.
The checklist is wonderful and it's exhaustive, and I find the lint on the top of the roof pretty crazy to be able to see that from satellite. And all of that, the exhaustive checklist, looking at the top of the building, which a lot of people would never think to do. Separate eyes are always good, additional sets of eyes. So who do you suggest goes with the IP to round or assess in the facility? I'm thinking maybe EVS or facilities and maintenance, those who can kind of speak to the construction standards. Who else should be going on these rounds?
Yeah, I think EVS is great. EVS often oversees the laundry process. And at one point, I would like to make in the study where they looked at linen when they cultured it prior to the point of use, they also looked at how often did the infection preventionists go to the facility, and they found that half of the infection preventionists had not been to the laundry facility in the previous year. And I would say during the pandemic, it was even harder to get out to the laundry facility. And then they also found that none of the facilities had ever invited the laundry provider to the infection prevention committee. So we want these relationships to go both ways.
I never thought about that.
Why not allow the laundry facility to walk through your facility and see how you're storing it, inside? I think that'd be very enlightening to them as well. But I think the person who should go with the IP to the facility is really whoever is responsible for the built environment. So usually that's facilities management or plant operations. And the reason I would take that person is because they tend to understand the ventilation system. So they can look at that ventilation and say, yes, this really is negative pressure, or hey, this is a directional airflow, not truly negative pressure. So they're familiar, the facilities managers, they're often charged in an acute care facility with monitoring air pressures in places like surgical suites. And they're familiar with getting reports from HVAC companies on how ventilation systems are balanced. So they would be able to understand all of those, charts on air changes, how they're measured. They would have the instruments to measure pressure relationships. I think it would be super helpful to take someone from plant operations.
Like I said, more eyes are better, I think, in any infection prevention issue usually. And the article also mentions that laundry facilities should contact the IP for an ICRA when doing construction. And I wanted to note that because in all my years as an IP, I've never actually heard of that happening. So I wonder how often that's overlooked.
I think it's frequently overlooked. And to be honest, until I worked with the laundry industry, I wouldn't have thought of it either. I was told by a laundry operator that they had continued doing their laundry during major demolition. And so, it's anecdotally, we've heard about laundry facilities that continue to operate while they are performing major demolition. It's just super important for the IP to be aware, because that's going to really affect the potential for dust on those textiles.
Oh my gosh.
Again, that's a contracting element. Yeah.
I know. That's why we do these shows, because these are things that some of us would never think of. And there's probably a lot of listeners out there that are like, duh, I've been doing that for years. But
there's so many things we don't know about laundry facilities and about hospital contracts, that I would love to hear from people who have been doing that for years. Because there's certainly something I would not have thought of. Yeah.
So as we're thinking about this is a great point, Nicki. Part of the reason for the podcast is to help, bring people knowledge as well as encourage research. But we know that there's a lot of people that are new to the field of infection prevention, or that, we've been doing this for a while and haven't heard these things. So
Can you tell us, Dr. Glowicz, are there any programs or trainings available to infection preventionists around safe linen handling?
So the APIC text has a chapter on healthcare laundry, and they really cite the HLAC standards. I do think that the HLAC standards are really informative. Again, they lack ventilation standards, but generally they're pretty comprehensive. And then the Association for Linen Management is a nonprofit organization. They've worked with the linen industry for a long time. They work across the industry, so they also work with hospitality and with commercial laundry. But they do have a certification in laundry management that if the IP, maybe might not be appropriate to the IP, but could be appropriate to someone in the healthcare facility that works with textiles. And the other thing that's fascinating to me is laundry chemistry. So how do they actually kill those organisms? And I think that would be really interesting. That is education that is offered by the Association for Linen Management and could be helpful to an IP.
Fantastic.
And I think I have one last question. I'm just wondering, what can infection preventionists do to get buy-in from leaders to make the necessary changes to the facility's linen handling processes?
Right. So in our article, we talk about the high mortality associated with mucor outbreaks and severe monetary and reputational consequences. So it's important that facility leadership understand how suboptimal laundering practices can affect patients. If laundry is contracted offsite, the combined federal regulation states that it's the responsibility of the governing board to ensure the quality of contracted services. Most folks on the governing board are non-infection preventionists, and they don't really understand the processes. So it is really, they are relying on the infection preventionists to give them that insight. So a well-written report of laundry strengths and weaknesses, coupled with an assessment of the potential patients who might be affected, can go a long way to getting buy-in. Understanding that when a laundry facility does not meet CDC standards, if it is off-site, it's not going to be observed by a regulator. It's going to be observed by the IP. And so the IP needs to really be able to communicate what that might mean to their patients. We have noted that laundry facilities are often distant from healthcare facilities, sometimes even located across state lines. So making sure that getting out to that facility and observing practices is a priority, and sometimes that requires travel expenses. So you've really got to help the governing board understand that if there is a textile-associated outbreak, they could potentially be held responsible. We had one facility. I know of one facility that dealt with a mucor outbreak by identifying a separate facility that could irradiate their textiles before supplying them to the very high-risk patients. That was super expensive, very, very expensive. And so, it's best for the healthcare facility to ensure that the laundry provider uses techniques that keep laundered healthcare textiles clean.
Great. Thank you so much. Lastly, I just wanted to comment that the risk assessment checklist offered at the end of the article is also fantastic. So I think that could be very useful to some of the infection prevention people out there as they go through and look at their linen processes.
I definitely agree. I'm sitting here planning a trip in my head, and that checklist will be going with us.
So you remember how I remember when the Joint Commission really started looking at dialysis contracts, and when they really started looking at those contracts. And so I think, even though the regulator is not going to go out to the laundry facility, they will look at those contracts. So I would evaluate that contract for, things like preventive maintenance of ventilation systems, for things like unannounced visits, I think that those benchmarks are super important.
Awesome.
Thank you so much, Dr. Glowicz. We've really enjoyed this. It's an interesting topic, one we haven't been able to cover, and I think the listeners will get a lot from it. So we really appreciate you joining us today and sharing your research and your knowledge.
I think we have learned that we have a lot more to learn about healthcare laundry. You start learning and you realize you have a lot more to learn. So yeah, I look forward to more work on this topic.
Yep. Thank you very much.
Thank you. AGIC Science into Practice is created by the Association for Professionals in Infection Control and Epidemiology with input from the APIC Research Committee and Pat Stone and Jean Brandt at AGIC, and APIC staff Shanina Knighton, Chris Ruiz, Bobby Gulshan, Christine Miller, Kaylee Deaton, and Kelly Lynn Russell. We work in partnership with Human Factor and audio tech Blake Alphin. To hear other AGIC podcast episodes and to access information about this podcast and the field of infection prevention and control, go to our website at agicscienceintopractice.org. That's AJIC scienceintopractice.org.